the question. So the question primarily is about what manufacturers and other stakeholders can do to kind of look at blockchain to implement it within their drug supply chains, and how they can potentially be partners in the solution. I work with a lot of people in the pharmaceutical industry on the security angle, so the people that are kind of the investigators, things like that, but not much with the tech people. So it's a really interesting dynamic where you may have a large pharmaceutical company, but they're in silos as far as their departments. So I think what we need to do is we need to have kind of a national dialogue about how this can be implemented within the federal requirements of the Act, and how it can actually be a solution that bridges some of the concerns that industry also has about interoperability and the cost of setting this up. It's an open standard, so again, you don't need to, in traditional, I've done some implementation on the industry side when I worked in industry a long time ago, is we tend to go out to consultants, contractors, things like that, proprietary solutions to set up things. But this is a solution that can be open to everyone, and that it should be pushed from the context of actually lower cost and kind of a shared solution. And including, I think one of the critical components that we could look at is how we can communicate this back to patients as a shared solution as well. Yeah, so that's a pretty complex question, but essentially, would transparency lead to more concerns about sharing information, especially when you're talking about jurisdictions or actors that are more concerned about confidentiality issues, things like that? So one thing I think is the design of the blockchain is really important. You can have private blockchains that only include certain actors, maybe certain authorized actors. And one of the good things about blockchain is you can actually authenticate licensure. So you could authenticate and say, well, only licensed distributors, not people in the gray market or people that are outside of the controlled supply chain, are allowed to be in this blockchain. And then you could basically, if a medicine had any information not associated with a controlled supply chain or a blockchain, then you could detect that it could potentially have, exited the controlled supply chain in the best way I can say it. But what I would say is the transparency component is really important, because you have this big ledger. And if there's one information point that looks strange, everyone in the ledger can detect it and report it, instead of reporting counterfeit medicines when they actually hit the end user. In the Avastin case, real quickly, it's a bad case of counterfeiting. Like, they actually had Turkish language or some other language on the labeling. If you're a good counterfeiter, you don't do that. Like, you make the packaging look really good, and the packaging was terrible. So that's the only reason why it was really detected. So for blockchain, again, it's a shared kind of surveillance network. Oh, that's kind of weird, shutting me off. So that's kind of the advantage of having a transparent network, and that's what we should promote. So that's a larger health policy question as far as drug pricing is concerned, and I'd be happy to have that conversation with you afterwards. I mean, one of the things that Avastin did do is they cut their distributors, and they said it was because of security, but when you have less distributors, it actually raises the price of the drug as well, because again, you have a more kind of, I don't know, a streamlined market. So there are potential effects towards one, directly selling it to the end user, but also there's a complex network of drug wholesalers that you'd have to kind of cut out. So that's a larger policy question we can talk about if you're interested.
Yeah, so I'm within the psychosocial realm, and I don't think it's so codified. There is a psychosocial team. They have a system. They keep track of their own interpretation of what's going on with the patient and their family. They talk about them and meet weekly and go around. And so I'm not sure there are actual milestones. It's it seems to me to be a bit more of an unorganized, kind of messy, intuitive process still. And other people might have more insight into this.
Well, I can add to that sort of from a clinical and patient-centric perspective. There is an increasing adoption and now mandate to use patient-reported outcome measures. You may recognize the acronym PRO or PROM. With CMS's first mandated bundle, which was for total CJR, practices are mandated to collect these PRO instruments, for example, called HOOS or COOS. They're patient-reported, but they sort of reflect both at baseline and a year out for those procedures, how patients are doing from a reported perspective. Now, there aren't necessarily any dates or any sort of thresholds to say a patient must be at this level, but practices are able now, both using our system but also in other places, to benchmark their own performance against other practices. And I do sort of believe that as patients become more savvy in terms of selecting healthcare providers, surgeons in this case, they may be able to start looking at how these physicians are performing on their PROM metrics against other benchmarks to make some selection decisions.
I think it is getting worse. And I think I was having this conversation with somebody yesterday just about that, about they're at Stanford and they have all these resources, but they're not the ones who need all these resources. This was on the professional side, not from a patient perspective. But that's the exact question that I ask, and it's also with regard to the level of psychosocial or mental health support that patients are receiving, in that we have these distress screening surveys, for instance, for oncology patients. There is now a mandate to roll these out, and it's just to capture right now the ones that are extraordinarily suffering with mental illnesses or depression or diagnoses, and that makes up about roughly 30% of patients, I've been told, from one particular hospital. And then there's the other 70% who are also probably suffering a lot, but they're not being targeted and resources aren't necessarily being delivered to them. And that's at a top-notch university hospital with lots of resources. And so there are folks who aren't being picked up in that screening, and there are folks who are not at top-notch university hospitals and who are in rural areas as well, or that there are other barriers to receiving resources. And I think societally, I've been getting the sense that this is considered a secondary, supplemental kind of care service that is being put onto the responsibility of families and friends to be your social support. And frankly, not everybody has the family and friends to provide that level of social support, or they have them and the level of relationship is not to the point where it's going to suffice for providing the type of support that the patient and family members need, or the family is suffering together and it's a complicated relationship and they can't all provide the level of support that they each need while supporting themselves. And so it's a complicated thing that's not really being addressed because we have these acute cases that also need to be addressed. And so in between.
Sure. So this project has been in stealth mode for about a year, and we just, our beta launched Wednesday. So I don't have too much insight yet, to be totally candid. We have three specific projects, three different building types, which we're not announcing at this time. But I'll say that I think our initial, we anticipate that we're sort of going to initially engage with the current stakeholder set in traditional ways, just to make sure that the product works and meets their needs in a very specific way. But
who are those current stakeholders?
Yeah, so typically that would be someone in facilities, typically today. And I think that that's sort of our step zero, is to just sort of be able to engage with that group, make sure that systems, very complex kind of cloud-based distributed synchronization platform and the basic user interface and multi-platform support, make sure that all the phones are supported up to 2 years old. And there's a lot of just mechanical complexities in phase one, which is really only 2 weeks. So we have a lot to do in those 2 weeks. The next step will be sort of one step out, which we articulate as participants. And this is a larger group of people that can participate at scale. So not necessarily bidirectional voice feedback, but can participate in the form of like choosing their favorite option, for example. And the nice thing about that is it can have a very large denominator. Those types of interactions scale up very, very nicely. You know, a little bit less context, but all of the same engagement and experience, and they feel like they're sort of along for the journey. So our expectation is that that second set will really be you know, head of cardiology, head of nursing, head of pediatrics, you know, people who are a little bit more not always able to engage with the architectural design process as much as they would like to, but really people who need to be an essential part of the process. And then from there, we'll transition into patients. Yeah. So I think that's kind of our and that's just a function of we're a 10-person team, so trying to like stage it out in a very linear path. But by the end of the beta, which is this fall, we will have covered all of those groups.
I think first it would be for the resources for personnel. I think there needs to be more people. And then I think it would have to be, I resist trying to go towards technology, but I think there's a lot of technological support that could be used to build up, to make the process more efficient for them. Like coordination, they talked about, you know, we talked to the psychosocial team, ways to get kids to open up, you know, technologies around that, getting across that barrier to like be able to say, I need help, but it's not you need help. Everybody can use support to different extents. I feel like getting over that hump of like it's the necessary process that humans go through. I think there could be outlets built for that. I'd put money into figuring that out.
I appreciated the sort of dynamic range across the 4 different technology-oriented kind of conversations, but also the sort of consistent themes across all of them as well. It was really an interesting conversation. So.
And I just think it's interesting, you know, kind of the life cycle of a lot of these projects, like conceptualization, implementation, you know, then further support. So I hope that all these projects can be successful. It's an interesting dynamic.